I'm consultant radiologist here in Rahman Medical Institute, Peshawar. So, topic of my presentation, I have confined it to ultrasound evaluation of thyroid nodule because of short of time, CTMR. If I include that, it will take a lot of time. So, I've just restricted myself to ultrasound evaluation of thyroid nodule. So, just to make it more interactive. I will initially show you a few cases. The objective of my presentation is to get you people aware of different terminologies used in thyroid ultrasound. Then have standardized reports with minimum variations so that all practitioners and surgeons can approach their evaluation in a similar fashion. And lastly, to develop a guideline for follow-up of the patient or whether to perform FNC or not. So just to make it more interactive, this is an ultrasound of a patient and who presents with a nodule with a lump in neck, and you ask for thyroid function test and ultrasound. The thyroid function test is normal, and on ultrasound report shows that there's a hypoechoic nodule in left lobe of thyroid gland, and the patient age is 59 years. So what impression do you get? What will be your management? How are you going to deal with this patient? So you can write in the message or any volunteer. This is the nodule. The options are, the next step is whether to do FNC. Step number B is follow-up ultrasound, or C is no further action. So choose the best answer. So Dr. Umar Farooq says that FNC, Dr. Maria Jan says follow-up, and Dr. Qazi says that if it is toxic. The thyroid nodule, TFTs are normal. So there is a mix. Some people are saying FNC, some are saying follow-up and FNC. Okay, so fine. So majority are in favor of FNC. Let me show you the second case. We will discuss these cases at the end of my presentation. Okay, this is another patient with similar history, same age group, same normal TFTs, and ultrasound shows a cystic nodule in left lobe with certain calcifications. So again, the same options. What are you going to do with this patient? This is case number 2. So again, option is FNC, and again FNC and FNC. So this was case number 2. And now the final case. This is the 24-year-old patient, again, same history, lump in neck. You advise TFTs and ultrasound. TFTs are normal. Ultrasound shows a large hypoechoic nodule in left lobe of thyroid gland. So what is your next management? Option A, B, C are, you can see. So I can see that ultrasound FNC, 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 and FNC. So everyone, can anyone tell me when not to do FNC? Okay, again, you are saying that if it is toxic. Well, you advise nuclear scan when the TFTs are normal. So here we haven't performed the nuclear scan. We are just dealing with the normal TFTs and the ultrasound. So let's proceed. So this is normal thyroid anatomy, which you know better than me. This is a cross-sectional anatomy because we deal with the cross-sectional images. So you can see a thyroid lobe, carotid, jugular, strap muscles, sternocleidomastoid muscles, esophagus, trachea. And that is how an ultrasound looks like. Okay, so this will be something different for you, something new for you. This is the right lobe of thyroid gland. This is isthmus. This is the left lobe of thyroid gland, right? This is the trachea. Now, the two black structures, these are the vessels. This is the common carotid artery, and this is the internal jugular vein. So this is the trachea. This is right lobe of thyroid gland. This is isthmus, and this is left lobe of thyroid gland. I hope all of you can hear me and can see my presentation as well.
Yeah, it's clear, Raja.
Okay, fine. So this was just a brief anatomy on ultrasound. Okay, so today I'm going to discuss with you ACR thyroid reporting system. Just like in BI-RADS, in breast imaging, we use BI-RADS system. In thyroid system is used. So thyroid system is being used by many countries, like from American College of Radiology, European Union. So there's a bit of difference in them. But today I'm going to discuss with you ACR thyroid. So you know that thyroid nodules are exceedingly common. In radiology, we come across thyroid nodule in every second patient. If we do CT chest, we also include lower neck sections, and we, out of 3 patients, we also always come across nodules in 2 out of every 3 patients. But remember that not all of them require biopsy. Okay, not all of them require FNA. So there should be a system, which one is to biopsy, which one is to just follow it up, or any other management. So which one deserves attention? So this presentation is all about that. So thyroids is basically, in thyroids we deal with 5 features of a nodule on ultrasound. It includes composition, echogenicity, shape, margins, and calcification. Each one of them is given 0 to 3 points. And in the end, we add all the numbers. And on the basis of that, we give them a thyroid score. So first we will discuss, this is the point distribution. We'll discuss turn by turn in detail. That is how we add up all the 5 groups. We get the cumulative points, and according to those points, we classify them into thyroid 1, 2, 3, 4, and 5. And more the thyroid score, more it will be malignant. So thyroid 5 is more malignant as compared to thyroid 1. So, and these thyroid levels then help us to determine what to do next, whether FNAC, follow-up, or no further action is required, just patient reassurance. So first we will discuss about composition. By composition, we mean whether a nodule is solid or cystic. Okay, the more solid it is, more are the chances of malignancy. So a solid nodule will get 2 points. So solid nodule is that nodule which is completely of solid component, or if it is more than 90% solid, we'll include it in solid. Cystic, as you all know, will be entirely fluid filled without any internal solid component. So cystic gets 0 point, solid gets 2 points. Then there is a mixed solid and cystic component, lesion, nodule. That will get 1 point, whether it is predominantly cystic or whether it is predominantly solid. If it is mixed, it will get 1 point. And then there's another form called spongy form. Spongy form means there are numerous tiny cystic foci. Again, that is benign, and that it carries 0 point. So this is a point distribution. So in cystic, if it is purely cystic, it will get 0 point. If it is spongy form, which contains numerous tiny cystic foci, again, it will get 0 point. Mixed solid and cystic, 1 point. And if it is solid, it will get 2 points. So more solid it is, more will be the chances of malignancy. Now here, let me show you this ultrasound. You can see a large cystic cyst in the thyroid lobe. Now, you should be aware of the various terminology we use in ultrasound, like hyperechoic, isoechoic, and hypoechoic. So for cyst, cyst usually appears hypoechoic. We call it anechoic. There is no shadow. So in ultrasound, hyperechoic is white, hypoechoic is black. Okay. So if a thing is white, we call it hyperechoic. And on CT scan, we use hyperdense. On MRI, we use hyperintense. So in ultrasound, we use hyperechoic for white and hypoechoic for black. So now, this is a cyst, pure cyst in lobe of thyroid. So if patient is not symptomatic, nothing required. If it is large, you can aspirate it. Another example. So this is trachea, this is isthmus, this is right lobe of thyroid gland. And you can see multiple tiny cystic foci in this nodule. This hole is the nodule, and multiple tiny cystic foci. That is called spongiform appearance. Okay. And spongiform appearance, I have told you that it gets 0 point, it goes more in favor of benignity. But again, you have to see other features as well, the composition, the margins, the calcification. So we don't have to decide on one feature only. So I'm just telling you about different composition things like solid cystic. Now another example. Now this is a mixed solid and cystic lesion. This black is cystic, this white is solid. Okay, so this is a mixed solid and cystic lesion, which is predominantly cystic. Okay, this carries 1 point. So chances of malignancy are more as compared to pure cystic lesion. Another patient, 65 years old, and you can see a solid nodule. Now this is a solid nodule. You can see a small cystic focus in it, but more than 90% is solid. So this will get 2 points for solid composition. So more a nodule solid, more will be the chances of malignancy. Now coming to the another feature, second feature, that is echogenicity. Again, by echogenicity, we mean whether the nodule is hyperechoic, hypoechoic, or isoechoic. We have to compare the echogenicity of the nodule with the thyroid parenchyma. Okay, so if it is increased, if it is more wide, as compared to the thyroid parenchyma, we call it hyperechoic. Okay, if its echogenicity is equal to the thyroid tissue, we call it isoechoic. If its echogenicity is less than thyroid tissue, we call it hypoechoic. And if the echogenicity is very less, even less than the adjacent strap muscles, we call it very hypoechoic. So the more the nodule hypoechoic, more will be the chances of malignancy. So hyperechoic gets 1 point, isoechoic also 1 point, hypoechoic gets 2 points, and very hypoechoic gets 2 points. The purpose of all this description is just to get you people aware of these terminologies, because I've seen in practice that clinician doesn't know much about hyperechoic, hypoechoic. So but you should know that more the hypoechoic, more will be the chances of malignancy. And it helps in overall scoring of the thyroid nodule, and it will help you definitely in the management of patient. So now coming to this one. This is the right lobe of thyroid gland. This is common carotid artery, and you can see a large nodule in the right lobe of thyroid gland. Now this is more echogenic as compared to the thyroid. So this will get 1 point. Okay. Another nodule, you can see a nodule in right lobe of thyroid gland, left lobe of thyroid gland, and you can see a large nodule in it. The echogenicity more or less same. The echogenicity in this nodule, you can see this is the normal thyroid, this is the nodule, they are more and less same. So they will get 1 point. Now here you can see a nodule in left lobe of thyroid gland. This is trachea. This is left lobe of thyroid gland, which is wide. You can see a black nodule, or we call it hypoechoic nodule. Now the chances of malignancy are more, and it will get 2 points. It is not blacker than this one. This is more black. So it is blacker than this one, it will get 2 points. Finally, there's a nodule you can see which is very hypoechoic as compared to the thyroid tissue. This is a thyroid tissue. It is very black as compared to thyroid, and it is also very hypoechoic as compared to the strap muscles, right? So it will, the chances of malignancy are even more high. More darker it is, more hypoechoic it is, more are the chances of malignancy. So it will get 3 points. So anechoic 0 point, hyper or isoechoic one and the same thing, 1 point. Hypoechoic get 2 points, and very hypoechoic get 3 points. In this table, you can see. So if you see a hyperechoic nodule, the chances of malignancy are less. Isoechoic less. Now, when it's just hypoechoic, the chances of malignancy are more. But when it is very hypoechoic, the chances of malignancy are more than 30%. Okay, so more darker, more hypoechoic it is, more are the chances of malignancy. Now coming to a shape.
Assalamu alaikum, sir. Sorry to interrupt you at this time. I'm a little bit confused about being cystic and solid. Like initially we discussed, when it is cystic, it appears more blacker, and usually cystic we say it's like okay, it's benign or it's not malignant. And then over here, like I cannot differentiate whether it's to call it cystic or the, मतलब मुझे ये लग रहा है कि ये cystic भी तो हो सकता है, या solid में हम इसकी consider कर रहे हैं, assess कर रहे हैं. अगर थोड़ा सा आप इस पे.
Okay, I totally agree with you. Even we face such difficulties in our routine practice. This is a pure cyst. Okay, it is completely black. Fine.
Shajan, can I interrupt you?
Yes, sir. Please.
What I got from the question is that what makes you decide about the cystic and solid component? Is it echogenicity or something else you have to decide on that?
Sir, there are two things. Number one, the entirely black, well-defined, without any posterior shadowing, it is cystic. Okay. Sometimes we face difficulty whether to call it hypoechoic. Let me show you the example. Now this is cystic. This is cystic. This is solid. Okay. This is solid, but solid can be black, like in this case. This case, this is solid, but it is not cystic because we can see some echoes in it.
Okay.
And sometimes, even when we face difference, what we do, we change the knobology. हमारे पास कुछ buttons होते हैं, हम इसकी gainness हम change कर सकते हैं. Even with that, if we face difficulty, use Doppler flow. Simple cyst will never show flow on Doppler. Solid will show flow on Doppler. Okay, so if I'm facing difficulty whether to call this cyst or solid, very hypoechoic solid, apply Doppler. If it shows flow, it is solid. Number one. Number two, cyst always has very well-defined margins. Very well-defined margins. Here you can see irregular margins. Number three, cyst won't have internal components. Here you can see some white and black things you can see. So these are the solid component. Okay. So whenever you face difficulty, discuss with your sonologist and ask him or her to apply the color Doppler. I hope you got the answer. Again, this is again a very dark hypoechoic nodule, but it is solid nodule. It is not cyst. Why? It is not well defined. It has lobulated margin, number one. Number two, it does contain internal some echoes, white echoes. And finally, if I apply Doppler on it, it will show flow. And these things, you know, you learn it with practice. I know. I hope I know you that you haven't seen much of the scan on ultrasound, but with practice you learn these things, and then things get easier. So this is a hypoechoic nodule. It is not it is a solid nodule. It is not a cyst. So more hypoechoic it is, more will be the chances of malignancy. Now coming to the shape. Shape carries paramount importance in deciding whether it is benign or malignant. And the most important is whether the nodule is wider or it is taller. Okay, if it is taller or deeper, it is more likely to be malignant. If it is wider, the chances of benignity are high. But again, I'm repeating, never ever depend on single feature. We have to combine all the 5 features and get the cumulative points. Now, this is 2 different nodules. Okay, these are the hypoechoic solid nodules. These are not cysts, because here we can see some echoes within it. I can see some echoes within it. Now, this is wider. It is not deeper. Okay, this is deeper. It is not wider. So, which one will be benign? The wider is more benign. And does anyone know the answer? Why? Anyone? You can message it. Okay, let me tell you. I can see. Okay, fine. The thyroid, normal orientation of thyroid gland is horizontal. Okay, this is thyroid horizontal. Whatever things distorted the normal planes of thyroid is more likely to be malignant. Benign things will be along the thyroid planes. So the more wider it will be benign, more deeper it will be malignant. So it will get 0 point, it will get 3 points. So it is easy to understand. There are no 1-2 points. If it is deeper, like in this case, it will be more likely to be malignant. If it is wider, it is more likely to be benign. So this 0 point, this is 3 points. So only this feature carry specificity of about 82 to 93%. Okay. Now coming to the margins. So margins are, I think, easy to understand. One with irregular margins, they are more likely to be malignant. One with smooth margins, they are more likely to be benign. So smooth margins, 0 point, lobulated irregular margins, 2 points. And if it's their extrathyroidal extension, there will be 3 points. We use term ill-defined when we are not sure what type of margins we are facing with. We are not sure, yeah, margin mujhe nazar nahi aa rahe, so what should I call it? So we call it 0 point. So let me show you a nodule. So this is a nodule in right lobe of thyroid gland. Now it is solid, okay, because it is not black. It is solid. It is isoechoic to the thyroid nodule, and it has smooth margins. Can you see margins? Yes, they are very smooth. So they go more in favor of benignity. Now, on the other hand, this is a nodule in right lobe of thyroid gland, and you can see lobulated margins. Okay, so the lobulated margins, they go more in favor of malignancy. Now here I see a nodule here. This is normal thyroid, but I'm not sure whether the nodule have irregular margins or smooth margins. So I will not give it any point. And finally, calcifications. Thyroid is notorious for calcification for seminal bodies, and all you know that. So we define calcification in few groups. The major divisions are microcalcification and macrocalcification. The microcalcification, to cut it short, is less than 1 millimeter. Macrocalcification are more than 1 millimeter. Macrocalcification usually have posterior shadowing. Okay. In ultrasound, we also use another term, punctate echogenic foci. This and macrocalcification are almost one and the same thing. They are also less than 1 millimeter in size, but macrocalcification are more discrete, but the points are different. And finally, there's some calcification which creates some posterior comet tail artifacts. Like here, this is now a nodule. This hole is nodule. This is right lobe of thyroid gland, and you can see macrocalcifications, dense calcification, which are causing shadowing. This blackish shadowing because of this calcification. We call it macrocalcification. Okay, macrocalcification goes more in favor of benignity. Microcalcification go more in favor of malignancy. So more smaller the calcification is, more the chances of malignancy are. Like here in this case, you can see thyroid, this is trachea, this is nodule in right lobe of thyroid gland, another large nodule in left lobe of thyroid gland. This contains macrocalcification as well as small tiny microcalcifications. You can see that, okay? So microcalcifications, they are more in favor of malignancy. Okay, one important thing is that not every calcification is associated with malignancy. Some calcifications we call is colloid. They cause some reverberation artifacts, ring down artifacts, like here. If you see, there's a nodule. Now this is a cyst. This is purely black, and this is cyst. It contains few calcifications, and this calcification is causing some posterior shadowing. This we call as comet tail artifact or reverberation artifact. Now this is important to understand because it is completely benign. This is simple colloid. Okay, so this is calcification with posterior artifacts. This, you can see posterior reverberation artifacts. This is this go more in favor of benignity. So again, to recall the calcifications. So macrocalcification 1 point, peripheral calcification 2 points, microcalcification gets 3 points. Okay, what in rest of the features like composition, echogenicity, shape, margins, if we get two different types of features, like there's a nodule which on one side is smooth, on one side it is irregular. So what points we are going to give to the nodule? We are going to the maximum, the one with the maximum points. So we will give 3 points to the for irregular margins. But with only difference is this case calcification. In calcification, if for example, if we see like in this case, in this nodule, we are getting macrocalcification as well as microcalcification. Macrocalcification get 1 point, microcalcification get 3 points. We will add them together. Okay, so the total points will be 4 points. Okay, so what about the size of nodule? Remember that nodule size is not an independent predictor of malignancy in thyroid here. Okay, we can see malignancy in small size nodules. We can see benign lesions, benignity in large size nodules. So never ever trust the size of nodule individually. Yes, you can consider the thing if it contains microcalcification, lobulated margins, then it is fine. But never go for the size of nodule independently. And that is why it is not included in the thyroid scoring system. And secondly, the size of nodules, you see if the size of nodule is C is less than 5 millimeter, the 10-year survival rate is 99.9%. If it is between 5 to 10 millimeter, again, not much difference. Even if it is 2 to 3 centimeter, the 10-year survival rate is 99. Yes, if it is more than 4 centimeter, the survival rate improves, deteriorates. But otherwise, up to 3 centimeter, there's not much difference in the size of nodule or the survival rate. That is why they have not included in the thyroid score. So what a normal thyroid ultrasound should consist of? It should describe size of the lobes. Right lobe measures this, left lobe measures this. About the thyroid parenchyma, about nodules, and what if we see multiple nodules? Then we should describe only 4 nodules, the 4 most suspicious one. Thyroid ultrasound is incomplete without cervical node evaluation, and I think we should have MDT for further management, where a radiologist, oncologist, surgeon, physician should all be sitting together to have management, to discuss management. Doppler does not have a significant impact in differentiating between the benign nodule or malignant nodule. Okay. Yes, Doppler does help us in differentiating between solid and cystic, like the one question you asked. but it does not reliably differentiate between the solid and benign and malignant nodule. Okay, when we call a cervical node involved or pathological, any idea? Okay, so usually cervical node, we say that more than 1 centimeter is pathological, less than 1 centimeter is benign. But again, I would say that never rest on the size of the node. Okay, so here comes few answer. Taller than wider, loss of shape, good. Circular shape, very good. Heterogeneous equation, all of you are correct. All of you are right. Okay, so size is not a good criteria. Again, rounded shape, the normal node shape is oval. Whenever it loses its normal shape, it is abnormal. Secondly, we can see a central fatty hilum in a node. If it is lost, it is abnormal. Then Doppler can sometimes help. Again, if the node is heterogeneous, if there are some cystic components, it is abnormal. Okay, calcifications again goes in favor of abnormal. So they, along with the size, size should not be individual predicting criteria for the nodes. So just let us sum up the presentation. We give again, according to the 5 features, we give the point from 0 to 3. We add them together, and if the point is 0, we call it thyroid 1, and it is benign, nothing to do, just patient reassurance. If the total points are 2, again, it is not suspicious, nothing to do. If the total points are 3, it is thyroid 3. It is mildly suspicious. Now what to do? Thyroid says that do biopsy if it is more than 2.5 centimeter. Okay. If it is less than 2.5 centimeter, follow it up. Thyroids 4 are those having points between 4 to 6 points. If it is thyroid 4, it means moderately suspicious. It means that go for biopsy if it is more than 1.5 centimeter. However, if it is less than that, follow it up. Follow it up after 1 year. Okay. And thyroid 5 is highly suspicious if the total points are more than 7 or more than 7. Go for biopsy if it is more than 1 centimeter FNAC, and less than 1 centimeter, you can follow it up. So that is how we can plan the management of the patient. Because again, I would say we see thyroid nodule in every 2 out of 3 patients we come across in ultrasound, okay, or CT scan or MRI. We cannot do biopsy for more than half of the population of Peshawar or KPK or Pakistan. So we need to have some management plan. Which one is to biopsy, which one follow up, which one nothing to do. So more are the points, more are the chances of malignancy. So up to 7 points, the chances of malignancy are more. Okay, which one is to biopsy? Biopsy is required usually for thyroids 3 to 5. Don't do anything for thyroid 1 and 2. And thyroid 3 and 5 only if it fulfills the size criteria. Okay. What to do if there are multiple nodules, multiple suspicious nodules? If a patient comes with more than 10 nodules, which nodule is to biopsy? The larger one or the smaller one? No. Forget about the size. Biopsy those nodules which carries more thyroid scoring, whether it is small, but if the thyroid score is more, go for that. And biopsy only 2. We cannot biopsy 10 or 20 nodules. So the biopsy of 3 or more nodules is poorly tolerated by the patients, and it increases cost as well as it does not add benefit to the patient. Okay. Okay, like every system, there are a few exceptions as well. In ACR TI-RADS, there are also few exceptions. Like what to do if a patient presents to you, to your surgeon, and he has already done PET scan for some reason, and there's a high epic nodule, and it is less than 1 centimeter in size. So in that case, forget about thyroids, go for the biopsy, because PET shows a uptake. So these are the few exceptions where you have to address the patient concern rather than following the thyroids. So these are the few exceptions. Secondly, if there are few nodules, there are few small nodules, but enlarged cervical lymph nodes, and you don't see any other cause of enlarged cervical nodes, the oropharynx, the nasopharynx, they're all fine, they're normal. You don't see any other cause of source of malignancy, and the thyroid nodule is small, go for the biopsy. Other exception is that whether you if you are treating, you're going to operate a parathyroid adenoma, and you did an ultrasound, and ultrasound shows a small nodule in thyroid. So you will prefer that कि मैं जी thyroid nodule parathyroid operate कर रहा हूँ, तो why not thyroid को भी उस वक्त में manage कर लूँ? So go for FNA for that, and if it turns out to be malignant or suspicious, so you can operate both of them in the same setting. Then if you see a small nodule even adjacent to a recurrent laryngeal nerve or trachea, you forget about thyroids. And sometimes you come across a nodule and patient says that I'm concerned about it, go for biopsy. Then the patient preference is more superior. Yeah, you have to respect that. So just give you a few examples. For example, this is a 45-year-old female who present with nodule. Now, how are we going to score it? First of all, composition. This is a solid nodule, so it will get 2 points. What about the echogenicity? It is black, it is hypoechoic as compared to thyroid, but it is not black as compared to the strap muscles. So it will get 2 points. 4 points, it contains a macro calcification and as well as small tiny micro calcifications. So overall, she gets 8 points for this nodule, and it makes her thyroid 5. So by thyroid 5, we mean that if it is more than 1.5 centimeters, we have to biopsy it. But the size of nodule is 8 millimeter. So thyroid says that don't biopsy it. However, when we did the ultrasound of the neck of cervical nodes, there were large suspicious nodes. Now, in this scenario, when there are large necrotic nodes in cervical node and you don't see any other cause of the cervical node, must biopsy this nodule then. So the point, my point is that always follow the thyroid nodule, but there are few exceptions. Okay, like here you can see a nodule in the left lobe of thyroid gland, and this is trachea. This is trachea. This is esophagus. This is common carotid. This hole is left lobe of thyroid gland, and this is a nodule. So although we cannot see recurrent laryngeal nerve on ultrasound, but this is basically a common location of thyroid nodule. By thyroids, we will advise this patient follow up after 1 year. What after 1 year, if the size of this nodule increases and it involves the recurrent laryngeal nerve or esophagus, and patient is going to blame you that you said me to follow up. Why didn't you operate at that time? Why didn't you do biopsy at that time? So these are the few exceptions when the nodule is in close proximity to the recurrent laryngeal nerve or that groove with the trachea. So try not to waste the time, try to biopsy it. Another example which I showed you, this is a thyroid gland. We can see a large parathyroid adenoma here. This is a parathyroid adenoma. And you're going to plan a parathyroid surgery for it, okay? But incidentally on ultrasound, you see a nodule in left lobe, okay? Now, it contains calcifications. So you are concerned, I'm going to operate on this nodule, so why not find out what type of nodule is this in the thyroid? Excuse me, please. So your preference will be, if it turns out to be suspicious, why not to operate both of them in the same setting? So on how to call it increase in size on in the size of nodule on the follow-up ultrasound. We call it increase in size when there's at least 20% increase. If it is less than 20%, we call it static nodule. If it is more than 20%, we call it increase in size. What to do in multinodal goiter? Multinodal goiter, usually we don't do anything with that. We don't educate FNAC for that. And it's up to you whether it is causing tracheal compression or not. You deal with that. So there are different types of imaging system. ACR, TI-RADS, NCCN, and Korean, European. The purpose of discussing this presentation with you people is that in Pakistan, unfortunately, we are not following any of the guidelines. I would blame the radiology people, even myself, that we are not using TI-RADS any system. We are not giving any clue to the surgeon. But I will also equally blame the clinician as well, because our reports always depend on the end user. Okay, so surgeons never sit with a radiologist. Tell us that you have mentioned hypoechoic nodule or hyperechoic nodule. What I'm going to do it? What I'm going to do with it? Whether to do biopsy? Just give me some hint, because I know you that you people do not know much about hyperechoic, hypoechoic, and more than 90% of our ultrasound reports are hypoechoic nodule in left lobe of thyroid gland. And you people are clueless what to do here. What do they mean by hypoechoic, hyperechoic? So the purpose of this presentation is just to get you people aware of these type of terminologies. Secondly, sit with your radiologist that we need to have a thyroid reporting, ultrasound reporting system on this basis. Just, and believe me that it will not take more than 4 or 5 minutes. Okay, but it will drastically change your management. It will help patient in that case. So whichever guidelines you adopt, it depends on you. But I think there should be a departmental policy regarding ACR TI-RADS, comparing it with the other guidelines. Although the sensitivity is not high, but the specificity is very high as compared to the other, and the accuracy is also very high as compared to the other guidelines. So this TI-RADS guidelines were initially used in 2015. Then there were some changes were made in 2017. So now they are using ACR TI-RADS in USA. So it is helpful. It is different. Like, it is not pattern based. It is point based. In some guidelines, there are half points are given, so that makes things a bit more complicated. There are no ABC subcategories. It is easy to follow, and no category for normal thyroid gland. Finally, our ultrasound report should not report more than 4 nodules. Okay, and if you are going to biopsy, do not biopsy more than 2 nodules. It will not add to the patient benefit. Yes, do biopsy the cervical nodes if you see that. Then there are different types of measurements of the nodule. Now, this is a wrong measurement. Always the measurement is first measure the longest axis of the nodule, then perpendicular to the longest axis. These are the 2 measurements. Again, we need to standardize them. So now coming to the first 3 cases, which I discussed in the start of the presentation, now come to that. So again, the question is, adult patient comes to you with a lump in neck. Now you can see a nodule in left lobe of thyroid gland. So this is a cystic nodule. It contains multiple tiny cystic foci. It well defined, it has smooth margin, there is no solid component. Now, what to do? So the total score is 0 points. What to do? Nothing. Excellent. So see, the management has changed of this patient. Initially, most of you were telling me that go for FNAC, right? So now since we have now we have understood that this is cyst, this is a spongiform appearance, this is not a solid nodule, nothing to do with it. Just leave it alone, nothing to do with it, just patient reassurance is required. Okay. So I am glad that you have got this point. Now coming to the second case. Again, this was a patient with cyst, in thyroid gland, and it contains calcification. So because of calcification, most of you said that go for FNAC. But again, it is causing reverberation artifacts. Simple colloid. Now what to do? Again, nothing. Okay. So excellent. I'm glad that you whatever I wanted to tell you people, you have understood that. Cyst with the calcification which is causing reverberation artifact, don't do anything, just reassure the patient. Okay. Now coming the final case. So this is a patient there was a large hypoechoic nodule on the left side. Now we are going to give it points. It is solid or cystic? It is solid. You can see things in it. Okay. So it gets 2 points for that. Okay. It is hyperechoic. It is black or white as compared to this one. It is black. Very good. Solid, very hyperechoic. Excellent. It gets 3 points for that. Okay. 2 or 3 points for that. 4 points. It does contain some calcifications. Now tell me, it is wider or it is deeper? Excellent. It is deeper. 3-4 points for that. So it has got some lobulated margins. This is lobulated margins. Okay. So overall score is more than 10. What to do now? Biopsy. So excellent. Now this patient requires biopsy. So I think we discussed 3 patients out of, initially you all said go for biopsy of all these 3 patients. And at the end of presentation, you said don't do biopsy in 2 patients, just in 1 patient. In that case, we have avoided unnecessary needling in 2 patients. Okay. So it had saved money for the patient. It had avoided unnecessary needling. Okay. So why should you adopt ACR TI-RADS for better patient care? Like in this case, we can avoid unnecessary needling. We can advise patient for follow-up or something else like that. Improve quality of report. Again, I blame our radiologist community. I blame myself to giving not to give you people clues about the nodule in our reports. Everyone is in a hurry. Everyone is in rush. But again, I would also hold you people accountable for that. You people never ask for these things. Okay. So it is not a blame game. I would say you just talk to the sonologist and radiologist of your department, of your hospitals, and get a standardized report. Go to them and tell them we need to have standardized report. Yes, we need to have a report like this. This is a sample report. You can download it. The sonologist or radiologist has just to tick it mark. Nodule number 1, size, right, left, estimate, just tick it up. Composition, just tick solid cystic. There are points are automatically there. Echogenicity, points are there. Shape, taller, wider, just tick it up. Margins, just mark it. Echogenic foci, microcalcification, mark it. Add total points, add here. If it is more, all the categories are here. It will give you that it is thyroid 1, 2, 3, highlight it. And it will give you the further management plan to you. So believe me, it is not going to take additional, not more than 1 or 2 minutes. But all you need to do is sit with them and just show them this paper that we need reporting on this basis. So if you start with your department, if you start with your hospital, and start your management policy according to this, we can have then I can take initiative in my hospital, you take initiative in your hospital, then we can all get together and we can have national policy for our country, or even for our city, or for province. We can have debate on the plus and minus points of the scoring system, but at least we should adopt some policy, some guidelines. So this is all about this is a brief of what we discussed in this last 1 hour. This is all about ACR TI-RADS, the 5 categories: composition, echogenicity, shape, margins, and calcifications. We add add them together, 5 categories. We according to these points, we classify them into TI-RADS 1 to 5, and below is the future management. So you are most welcome to ask any questions regarding ultrasound imaging. The forum is open to all.
Thank you very much, Dr. Shahjahan. It was very much informative and educating one. Really, I learned a lot from your lecture and from your description. And really, it's a need of the day to develop the methodical and scientific things forward. And that's only possible when different people from different departments, they're set together and they discuss things with each other, and that's how they can increase their skills and knowledges. So MDT is really a need of the day.
Sir, yes, sir. So what we are lacking in our country is that we don't are conducting MDTs. In our hospital, we have started breast MDT. We are doing neuro MDTs, but we learn a lot from you people, and we then come to know that what you people need from us, and it is only possible when we sit together. And I think MDTs are the best platforms to discuss these things and plan these things.
So very much right. At the end of the day, the aim is to improve patient's care, and with this much a single investigation, you can avoid unnecessary investigation, unnecessary treatment and surgery also, not only investigation. So for participants, the forum is open for discussion. Please raise your hand and ask questions personally if it's possible.
Assalamualaikum, sir. Sir, I would like to ask a question, sir, which is basically...
Who is this?
Sir, this is Dr. Mas Qureshi from LRH. And I want to ask Sir Shah Jahan, it was a really good presentation, but why do we use horizontal then vertical scoring, as you said in your lecture?
Scoring?
No, sir, you said first हमने जो है वो horizontal measurement करनी पड़ती है, then we have to do the vertical measurement. Is it because of the same reason?
Okay, I got your point. So the nodule, basically every nodule should be, the measurement should be given, 3-dimensional measurement should be given. Some nodules are thinner but longer. Some nodules are wider but not deeper. So I have shown you in the last page that always ask your sonologist or radiologist to give this measurement of the nodule in 3 dimensions: longitudinal, and maximum 2 axial dimensions. It will give you the approximate volume of that nodule. So one nodule, one measurement cannot give you the accurate measurement because some nodules are rounded, some are deformed shaped, some are fatter, some are more wider, some are more deeper, some are thinner. So just to avoid that bias, ideally it should be 3-dimensional measurement.
Thank you, sir. Thank you so much.